And thank you for joining us today on this 24th day of March 2018 on Health Digest with me, Dr. Mercy Korir. Now, today we are discussing TB. This is tuberculosis. And the 24th day of March every year is marked as World TB Day. This follows in 1882 when Dr. Robert Koch announced that he had discovered the bacteria that causes TB. Now, globally, TB is said to claim 4,500 lives daily, on a daily basis. In 2017, 1.8 million people died because of TB. And this health, economic, and financial consequences of TB is the focus of our discussion this evening. And to help me have that discussion are three panelists. And to my immediate left is Josephat Asande. Josephat Asande is a former TB patient, and he'll be telling us about his experience, his treatment, and what he has learned from this TB experience. Next to him, the lady is Elizabeth Mweni. Elizabeth Mweni is the Nairobi County TB, Leprosy and Lung Disease Coordinator. And last but not least is Dr. Herman Weyenga, who is from the Centers for Disease Prevention and Control. He is a public health specialist, specifically in HIV, TB, care and treatment. And to kick us off in this discussion, we'll start with Josephat Asande.
Yes. When
you first presented to the hospital, to the health facility for treatment, what were your presentations? And did the healthcare workers immediately pick up what it is that was ailing you at the time?
First, I presented to the facility. I had a very productive coughing, yes. But I went to several hospitals. So it took me around almost one month to be diagnosed to have TB. Yeah.
And all this time when you're going from hospital to hospital, what are they treating you for?
So the first hospital I visited, they told me that it was asthma, so something like that. So because I couldn't be able to breathe well, so they suspected to have asthma. Yeah.
And after that, did you go to a second facility to seek a second opinion? When they were treating you for asthma and you're not getting any better, yeah, did you go to another one for a second opinion or for a different?
Yes, I even went at that one. Yes. So they took me an X-ray, the picture, and then actually I was started on treatment through X-ray. Yeah.
Mm-hmm. And I want to just pick on to just ask Elizabeth Mweni. It's a common story, what Josephat is talking about, where health workers, I don't know if it's lack of high index of suspicion, or is it that we think we have managed TB, that they actually miss or don't suspect that somebody could be presenting with a possible TB, and particularly if their HIV status is negative. Mm-hmm. Why is this the case?
Okay, thank you very much. I think it's a gap that we found after the prevalence survey that we had in 2016. A patient can come even to more than 5 times to a facility before they are diagnosed to have TB. You know, TB mimic other respiratory tract infection. So it was a gap that we found out, and we have done a lot to sensitize our healthcare workers so that they have the high index of suspicions once a patient presents with a cough to a health facility. And we are doing a lot on that because we are also doing the active case finding, so that every time a patient comes to a facility, they are able to ask the questions even before the patient tells them what they are ailing. Yeah, so it's something that we are working on.
Okay. Dr. Herman, you are in the TB care field. You're a public health specialist. In your opinion, why are the healthcare workers not having a high index of suspicion when it comes to TB?
Yeah, I think one thing that has been said is, and this is a problem that is the world over, we had about 10 million people with TB last year, and only 7 million of these were identified, 3 million were missed. So it's a global problem. And I think one of the issues is, as Elizabeth has said, is our frontline healthcare workers do not think about TB as a possible diagnosis until a patient has come so many times to the facility and they have treated for other things. that is when they start thinking about TB. So we really need to have them to have this in mind. Someone said that what an eye has never seen, the mind doesn't think about it at all. So we need to really ensure that our frontline healthcare workers get to think about TB as the first thing.
And is it only a Kenyan healthcare worker issue, or do we see it even in other countries, especially where the CDC is at?
No, it's a global problem. And I'd say that we missed globally, we missed 3 million TB patients last year. And I think if we come to Kenya, we are part of the high burden countries that contribute greatly to the global TB problem. So it's a big problem globally, and Kenya also is a major contributor to the proportion of TB cases that are missed.
Okay. Coming back to Herman, to Josephat, after visiting several facilities, you're being treated for asthma, you're not getting any better. What were you, at this time before you were diagnosed, what were you thinking about? Did you ever suspect that it could be TB from your own point of view?
Actually, no, because, we trust doctors a lot. So when you are being told that it's asthma, and then you take treatment, after all, you find that you are not getting it better. So I was not suspecting to have TB. Yeah. And
before the diagnosis, or when they took the X-ray and told you it's TB, did it make sense to you? Did you sort of have an idea of where you could have contracted TB from, or were you surprised?
Of course, I was very surprised because when you are being told that you are going to take medicine for 6 months, it's not easy. It's not easy. So I was very surprised. Yeah, but I said, as long as I'm going to cure, then I'm fine. So I just took on the treatment. Yeah.
Okay.
Yeah.
Herman was diagnosed using the X-ray, or rather, the X-ray is the chest X-ray is what led to his diagnosis and eventual treatment. Do we have the diagnostic capability as a country? And I want to start with Herman. As a country, do we have the diagnostic capability for TB?
I think this country has done a lot in terms of TB control. We have a very huge diagnostic capacity. And one thing that I would like to mention straight away is that we have one of the best diagnostic tools in the world called the Gene Expert test. This is a test that, compared to the smear microscopy that we used to use long time ago, it has a very high sensitivity of identifying people with TB. It can pick a very large proportion of people with TB among those people who have symptoms. And it also has the capability of identifying if someone has resistance to one of the most important drugs that is used in TB treatment called rifampicin. We do have close to 160 machines distributed in each county in this country. And to ensure that every person, even in the smallest facility in this country, is able to have access to this, we have a sputum transportation network, where we either have riders, motorbike riders, picking sputums from one small facility to where the machines are operating, to ensure that they are tested and the results are sent back using the latest technology we have. We have email sending back the results to the healthcare provider that requested for the test, and we also have telephones, text messages that are coded to prevent any person accessing the information being used to send this information to the people who are supposed to make decisions concerning the patient. We also have 2 large culture laboratories in Nairobi and in Kisumu supporting what we call more advanced tests on the people who are suspected to have drug-resistant TB. And we also have X-ray facilities in each county, and with thanks to the government of Kenya for ensuring that we have digital X-rays installed in major county and sub-county hospitals in the country. And we know that these tools have a very important, very high capability of identifying TB. So in terms of diagnostic tools in this country, we do have the capacity, and we are able to identify all patients if we are to get there.
Okay. And I'd like Mweni to also comment on the same, on the diagnostic capability and the tools that he's talking about. Do we have them in Nairobi County and are they in use? Because we know one of the things that the Kenyan health system has been accused of is sometimes having all of these fancy equipment, the digital x-rays is talked about, or the gene experts, but they're in stores, they're not in use, and therefore affecting those who will be seeking those services. So do we actually have and use this diagnostic capability in the county?
Yes, I'd like to talk about Nairobi. Currently, we have 14 public gene expert machines that are installed in different big hospitals in Nairobi. They are very much in use. In fact, sometimes they're overworked. Even the modules sometimes go down so that they need regular servicing. We have the network referring system, the one he's talking about. Periphery facilities are able to refer the samples to this gene expert site where they get samples, especially those who are HIV negative, the children, the contact of drug-resistant TB. They are able to send the samples to this gene expert machine, and they are able to get alerts, results straight from where they are, because the results usually come as an SMS alert on the phone and also through email. So they are really in use and they are really working.
What happened that made you conclude that there's a lot of stigma when you're going through treatment?
Okay, for example, like when my friends knew that I was suffering from TB, they started separating me. So it reached a point whereby you are even put in a certain room. You're not able even to share utensils, maybe eating together, you see? Yeah, something like that, yes.
Okay, Mweni, yes. I want you to comment on that, because TB, it can be treated. Yes. It's manageable.
Yes.
So why is there a stigma, as he's talking about, where people are keeping away from him?
Basically, I'll talk about the stigma. The stigma, you know, most people still associate TB with HIV. They're saying when you have TB, most likely you could be having HIV. But I tend to disagree. I think this is something that we have been working very hard, even with our healthcare workers, to ensure that we remove this stigma. It's only a small percentage. I think nationally it's at 27% of those who are co-infected who have TB and they have HIV. Nairobi, the patient that we had last year, that was around 12,800. Only 31% were HIV positive. So most of our patients who have TB are HIV negative. So there's still that relationship that people think when you have TB, you could be having HIV. So it's something that we need to work out in our communities to ensure that if someone has TB, it's not a must that they have HIV. In fact, large percentage of those who have TB, they are HIV negative. So it's something that needs to be worked on, and we are really trying to work on, starting from the facilities and even using our community volunteers when they are passing on messages in the community to ensure that because we are doing a lot of active case finding. People are still scared. If I'm told I have TB, could I be having HIV? So those are the things that we need to work on to remove that stigma, to ensure that even if one has TB, it's not a must that they're HIV positive. Yeah, they can be taken care of and they can be cured. Yeah.
And I want to address this to Herman, Dr. Herman, who is in the field of HIV and TB care. As she's mentioned, in her opinion, the stigma around TB is associated with HIV. Then that brings in stigma on HIV also, and we know it's a manageable disease. Is it only that the stigma around TB is because people have always associated it with HIV, or are there any other reasons why people would see TB as something to keep off from, or somebody suffering from TB as somebody to keep off?
I think HIV has played a very important role in driving this, major role in increasing the stigma around TB. But we also have issues of historical issues where before the treatment of TB was discovered, people used to be put in sanatoriums, isolated in TB sanatoriums and so forth. And this created some background sort of stigma where it's like if someone has TB, they have to be isolated. But we know today that if one is identified to have tuberculosis and they are put on treatment, within a very short period of time, within 2 weeks, they lose infectiousness because we have very highly effective drugs like rifampicin and isoniazid, which will kill majority of the bacteria that the person will be exhaling. So we do not have to get people isolated or stigmatized because they have a TB. TB is just a disease like any other.
Okay.
Yeah.
Now, you have mentioned something very important, and it's something that I've come across where when somebody has been diagnosed with TB in the household, then people want to keep the children away from them for some time. Is it advisable that during those 2 weeks or maybe 1 month, when somebody is on this intensive phase of treatment where you want to actually kill most of the bacteria that is causing TB, is it advisable then that that person is isolated or quarantined, if I may call it so, for that duration so that they don't, pass or infect the other people in the household?
I think one thing that we miss, and I think even at the health facility, is the fact that by the time someone is identified to have tuberculosis, they've already exposed the people around them. And that's why we really talk about, if you have cough, report it to the healthcare provider, even if they don't ask. And it is important that we exercise infection prevention measures at home if someone has tuberculosis. But again, we have to be very careful not to start stigmatizing individuals. It's great for this person to spend a lot of time in where there's open air, in the outside, open windows during the day. And if we have very young children in the house, we do not want to continue exposing these children if we already know that we have tuberculosis. So it's advisable, but you should not overdo it to the extent that now people say, ile ni room ya Haman, he stays there because he has this. I think we do it to the it is overdone sometimes, and this causes a problem, a negative effect to the person who is getting treatment, and also the other people who would want to seek care for similar symptoms, but they fear that they will be treated negatively. So I think the most important TB infection control measure is to get the person who has been diagnosed to have tuberculosis take their drugs, supported to take the drugs, have the windows open. And if we do not have a room that has adequate ventilation, this person can spend most of the time outside of the house. Yeah.
Okay.
Just to add on what Herman is saying, once we diagnose a patient with TB, we usually tell them on infection prevention measures when they're back in the house. They need to ensure that they use, maybe when they're coughing, they don't just cough open mouth. They need maybe to be closing their mouth, spending a lot of time outside. And if they're children, especially those who are under 5, the contact, we usually advise them to bring them to the hospital so that they are tested. And if they don't have TB, we usually give them an IPT, isoniazid prevention, so that they kill the latent bacteria. Yeah, children, the immunity is so low. So we usually advise them, they bring the contact. Yeah.
Okay. Yeah. And how long is this treatment? Let's say if you start a child on the prevention treatment with isoniazid, as you've said, how long is this treatment, and is there any special precaution that people should take while they're on this particular treatment?
Okay, the treatment is usually 6 months. It's isoniazid. And the only precaution, basically, you have to screen for TB. This is only one drug we are giving. So we need, when these children, even adults who are HIV positive, we usually give them the IPT therapy. We usually screen them for TB. If they don't have TB, then they qualify to have the isoniazid for 6 months. Then we always advise on the side effect. Isoniazid usually get the peripheral neuropathy. We advise even the mothers, if they have the young ones, to check on delayed milestone.
You or Herman, to just simplify what peripheral neuropathy is. For the sake of our viewers who may not really understand this big terminology.
Is it the tinkling sensation because of lack of, the isoniazid will remove the vitamin B. So that tingling sensation you usually feel on the legs, that's the peripheral neuropathy. And if you have a small child, if a child was walking, they'll have delayed milestone. They'll refuse to walk. Maybe if they were crawling, they'll refuse because of the pain they are feeling on their feet. Yeah, so it's something that can be controlled because we usually give pyridoxine to ensure that it counteracts the effect.
And pyridoxine being vitamin B.
Yes. Yeah.
Okay.
Yeah.
Okay. Yeah. All right. And before we just take a break, I'd like to find out from Josephat, what medications were you given, and how was this specific experience of actually being on daily medication? How was it?
Sorry, come up again.
You were put on treatment for TB.
Yeah.
How was it taking medication on a daily basis for a specific period of time?
Okay, as I said earlier, ni kujitolea, so it's your life.
Or did you suffer any side effects that made you feel like, no, I don't want to take these medications anymore?
Yes. Yeah. So there's sort of side effects that comes along when taking TB treatments. Yes.
Okay.
Yeah.
All right. So I'd like us to take a break from that juncture, and when we come back, we'll continue on this discussion on TB, and we'll be looking at the vulnerable groups that are likely to suffer from TB. We'll be looking specifically at the prison service in Kenya and